Welcome back to the Emergency Medicine Clinic's podcast. I'm Patrick Manley, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles centered on a central topic. Today we'll be discussing the August 2015 issue on cardiovascular emergencies, guest edited by Drs. Semhar Tewelde of University of Maryland and Joshua Reynolds of Michigan State University. Today we'll be speaking with several authors from the issue and discussing their articles. First up is Dr. Laura Bontempo from the University of Maryland to discuss the article on atrial fibrillation she co-authored with Dr. Eric Goralnik of Harvard. Dr. Bontempo, welcome.
Thank you for having me.
I noticed that the both of you wrote another article on this topic around 2011 for us. I was wondering what you feel are the main new developments since that last article.
Well, the truly main new development is the assessment of thromboembolic risk for all patients. That really wasn't a clear, strong recommendation or guideline in 2011. And sort of as anticipated, it did become one in 2014. Previously, it was thought, well, if you're rhythm controlled, well, then you're rhythm controlled, and we have you back in sinus rhythm, and you can go on your way. But now we know that actually, unfortunately, the majority of patients do not remain in sinus rhythm at 1 year follow-up. So at some point, they reverted back to atrial fibrillation. So they do have an increased risk of thromboembolic events. So now, regardless if you're rate controlled or rhythm controlled, even if you are returned to sinus rhythm while in the emergency department, your thromboembolic risk should be evaluated through the CHADS-2 VAS score and appropriately treated. If you qualify for anticoagulation with, say, a CHADS-2 VAS score of 2 or greater, then even if you're in sinus rhythm, we're going to go ahead and start you on an anticoagulant agent.
Is there anything in the pipeline you see coming that maybe a new treatment method in the next couple of years?
Sure. Actually, that's an excellent question. I think that there truly is, and this is sort of looking at the literature, not yet guidelines, but more maybe my conjecture about what may be coming. And I really think there are two main things. One is that, looking back at the two landmark studies for atrial fibrillation, the RACE study and the AFFIRM study showed no benefit, as I said, of rate control over rhythm control. However, in those studies, patients that were rhythm controlled were not anticoagulated because the thought was you were back in sinus rhythm. So there is no mortality benefit between the two branches of treatment. I suspect now that we are addressing the thromboembolic risks of all patients, it is possible, and I would even go as far as to say likely we're going to find out that rhythm control with appropriate anticoagulation may turn out to be the better option. So I'd keep an eye on that, see what the data is going to show us over the next several years now that we've changed our practice and are addressing the thromboembolic risks for all patients. The other change I think that's really starting to evolve is that 48-hour window within which you can pursue either rate or rhythm control, I think, is going to shrink. It really does look like that magical 48-hour number isn't quite so magical, and we may really only be able in the emergency department to address a rhythm control strategy in someone with symptoms for perhaps even as few as 12 hours. So I think that 48-hour window of rate versus rhythm option is going to shrink significantly.
Before we move on, is there anything else you would like to underline from the article?
Well, there's a lot more stuff in the chapter laid out as far as calculating risks and your options for rhythm control and rate control. So it is all in there. I think as long as the emergency physician realizes that as of right now, within that first 48-hour window, it is really at their discretion based on their bedside assessment of the patient and the patient's comfort, which therapeutic option to choose. That's a very important point I wanted to get across. And beyond that 48-hour window, really, we're just going strictly with rate control and anticoagulation. And then the patient's care can be passed off to the next clinician beyond that.
Now let's go to Dr. Ashley Strobel from the University of Minnesota to discuss her paper on the critically ill infant with congenital heart disease. She co-authored this paper with Dr. Lee N. Liu. Dr. Strobel, welcome.
Thank you for having me.
We haven't had an article on this topic specifically in quite some time. Would you care to give us some of the highlights or pearls and pitfalls from the article?
Sure, absolutely. I think some of the points that Mimi, Liu, and I really wanted to bring to the emergency provider, whether you practice in the community, an academic tertiary center, or otherwise, that critical heart disease in children is very real and somewhat prevalent. almost matching the prevalence of sepsis in the neonate nowadays after the vaccination era. So, a couple big things is when you have a neonate in distress, it's obviously very high stress in the department as well, and we want to kind of simplify things. So a couple points to really simplify things. If you've got a baby who's probably less than 2 weeks to less than a month, you're probably going to have more of a left obstructive lesion, or at least a ductal dependent lesion, whether right or left. And these children will often benefit from prostaglandins. They might be blue, they might be gray. And so our article kind of goes into how do you differentiate between these children and decide, is that a cyanotic neonate in distress, or is that a shocky neonate in distress? And how do we take the next steps to evaluate that? And how do we take the next steps to correct whatever process might be going on? Then we've also got the kind of bigger baby, a chubbier, about 6-month-old baby who starts to have those little fat rolls and hand dimples. And those kids are typically going to come in with poor feeding. And those are usually the product of more of a shunting lesion. So whether it's a left to right shunt and the baby's pink, but in distress, or whether it's a right to left shunt and the baby is blue and in distress. So we try to make it very easy by simply looking at the child and doing what you did in kindergarten, knowing the color of the baby, whether they're pink, blue, or gray, and then thinking about the age of the baby. We also included a nice toolkit kind of going through different tests that are non-invasive that you can easily do in any emergency department. The hyperoxia test, checking for murmurs, checking pulses, blood pressure differentials, pulse ox differentials, getting an EKG, a chest x-ray, and then also empowering some of our emergency physicians who are very handy with the ultrasound to place a probe on the child's heart and at least just take a peek and see if you see 4 chambers or if you see good pump function. So these are kind of the main take-home points of our article that we really hope to highlight and make it easier to pick up this, what we kind of think of as a needle in a haystack.
Is there anything maybe that you haven't covered yet you would like to highlight for the listeners?
I think one of the highlights that I took from putting this article together and also from my interest in this topic is that these kiddos can present anywhere at any time. And so making sure that every emergency physician is prepared, because sadly, 1/2 of the infants with a misdiagnosis of a critical congenital heart diagnosis, if they were missed and had a poor outcome, it was typically at home or in an emergency department. And frequently these children will present to their nearest ED rather than where they get their care, and that may be a non-tertiary ED. So when they do suffer from distress, it's the nearest hospital that will see these children. I think the main points that we have is just knowing the age of the children, the color that they present, going through our toolkit, and then from there, feeling comfortable knowing if they're pink, well, they have probably enough oxygen. If we give them more oxygen, it won't help. So no oxygen there, but perhaps that child will need some fluids. The blue baby, obviously they need oxygen. They're blue. So feeling comfortable giving those children oxygen. If they have white lungs on chest x-ray, whether they're pink or blue, probably IV fluids aren't going to be the most helpful for those children. And then lastly, for that gray baby, knowing that IV fluids are exactly what they need because they're shocky, and every shocky baby probably needs IV fluids, so feeling comfortable giving that. They're gray, so they're dusky. They're probably looking more blue. They need oxygen, feeling comfortable giving those children oxygen. And lastly, that neonate who presents shocky, feeling comfortable initiating prostaglandins, but also knowing that this has adverse effects. And the biggest one, if you're in an outside facility, is to have a ventilator very close to the child, so that if the prostaglandin does cause apnea, which is a known adverse effect from prostaglandin, that we have equipment ready to go after initiating that medication. So the main take-home points are age, color, the toolkit, and then feeling comfortable when to use oxygen, when to use IV fluids. and when to start prostaglandins.
I just want to take a quick pause here to let our listeners know they can receive an exclusive discount on the issue we're discussing today by visiting us.elsevierhealth.com/EMC podcast. So let's move on to Drs. Michael Scott and Michael Winters from the University of Maryland to discuss their article on congestive heart failure. Gentlemen, thank you for joining me today.
Thanks for having us.
Thanks so much, Patrick, for having us.
Dr. Scott, can you take me through what you feel to be some of the key takeaways from the article?
Sure, Patrick. Thanks for asking. I think one of the biggest things that we tend to harp on a lot is, I think when people come in with congestive heart failure, people are always immediately reaching for diuretics and especially Lasix. It's important to note that probably at least half of the people that come into an ED with acute decompensated heart failure are actually not total body volume overloaded. And there's kind of two different phenotypes of people that come in. One is sort of what we think of as the traditional congestive heart failure patient who has a significantly low EF and has had a more subacute increase of edema and those kinds of things, bringing on shortness of breath. And they are total body volume overloaded, and those patients are going to need significant diuresis to fix their shortness of breath and their issues. But actually what may be a little more common that we see in the ED is more of what we call a vascular failure. And this is often more the initial pathophysiology that's tipping these people over is often a large increase in blood pressure and afterload. And often these people actually aren't total body volume overloaded. So it's important to be able to distinguish between these two groups and to know that in most people, certainly in the acute ED management, is that Lasix doesn't actually make up much of our initial management. With that, most of your management is going to be aimed at hemodynamic optimization. And with that, we're trying to decrease both afterload and preload. The mainstay really are two things. One is non-invasive positive pressure ventilation, and the other is mostly nitrates in terms of pharmacologic treatment for this.
Dr. Winters, there's a large breakdown of pharmacologic options in this article. Can you take me through some of that?
Sure, happy to do so. I want to re-emphasize Mike's points about the majority of the patients that we are going to see coming in to the ED with acute decompensated heart failure are not total body volume overloaded. So really being aggressive with the initiation of non-invasive positive pressure ventilation right up front, not waiting for a little while during their ED course, but getting this therapy started early. And then in terms of pharmacologic therapy, as Mike just indicated, your go-to medicines, your first-line medication is nitroglycerin. And often the issue is we start too low and we escalate too slow with nitrates or nitroglycerin. You really want to be very, very aggressive with these patients, starting off at 80, 90 micrograms per minute in terms of an infusion, not really the 5 or 10 that many of our EDs, many of our nursing protocols, many of our hospital protocols would suggest. Really much higher doses and quick escalation to decrease that preload and some afterload reduction. The majority of patients will actually respond simply to non-invasive positive pressure ventilation and aggressive nitrates. There may be some patients who still remain in extremis during those cases, that are the patients that don't respond to those two initial therapies. For these, you can try afterload reduction, and there's some evidence to suggest that afterload reduction with the administration perhaps of an angiotensin-converting enzyme inhibitor, a one-time dose, has resulted in reduced rates of intubation along with intensive care unit admission. So non-invasive positive pressure ventilation, aggressive nitrates, afterload reduction for a smaller percentage, and then finally, once you have better hemodynamics, improved renal perfusion, the addition of diuretics can come in towards the end, but by no means should diuretics, as Mike indicated, be first-line therapy. For those much rarer patients who present with signs of cardiogenic shock, you may consider adding an inotropic medication, and the most common of which is dobutamine. That can be initiated around 2.5 micrograms per kilogram per minute and then titrated to effect up to approximately every 10 minutes to, in general, a maximum dose of 20 micrograms per kilogram per minute. That forms the really bulk of medical therapy or pharmacologic therapy for these very complex and complicated patients.
Are there any final points you'd like to touch upon? I'll start with you, Dr. Winters.
I would add just a final comment, and Mike does a great job discussing this in the article, but many of these patients who come in with a history of CHF also have other significant comorbidities, including chronic obstructive pulmonary disease or COPD. And for the emergency provider, it can be very difficult up front to determine whether you're dealing with a COPD or CHF exacerbation. And what I'm getting at is really the utility of ultrasound in the emergency department and the ability to do a quick ultrasound at the bedside, not waiting for radiology to help confirm that you've got signs of congestion, but really looking for B lines and other evidence of CHF so you can initiate the therapy we talk about really within the first few minutes of patient arrival and your quick diagnostic ultrasound.
Dr. Scott, any final points?
Yeah, I think the other thing that bears specific underlining is the changed role of the balloon pump. Now, obviously, most emergency providers aren't going to be placing balloon pumps themselves either way, but with the new data out showing that in the past the balloon pump has been an important part of treating heart failure and or cardiogenic shock in the setting of an acute MI, and the new data is showing that outside of mechanical complications, there's really no benefit. And so there's really much less indications for the use of balloon pumps than there used to be.
For our last article breakdown of this podcast, I am joined by Drs. Michael Allison and Haney Mallemat of the University of Maryland. Their article is on the emergency care of patients with pacemakers and defibrillators. Dr. Allison, can you take us through some of the key takeaways from this article?
Well, thanks, Pat, for having us on the podcast. Just wanted to highlight that patients with pacemakers and defibrillators are going to be the most common cardiac device patients that we're seeing in the emergency department. So we really ought to know what to do when they come in dire circumstances and with their emergencies. One of the first key points is about the pacemaker patient and how to deal with a patient with a pacemaker malfunction. Most patients with pacemaker malfunction have been categorized as failure to pace, failure to capture, and failure to sense. But that's really the framework that's been put forth in textbooks and prior articles. And I think we should get away from that, because when pacemakers malfunction, it doesn't matter what the cause is at that point. Usually it revolves around the interrogation to figure that out, and that's not coming till later. What we really should focus on is the emergency management of these patients and what to do. So they need a really good history and physical about what's going on. Has there been new ACS type symptoms? Has there been trauma? Is there a lack of follow-up? Any medication changes? Any device reprogramming? And then get a basic workup of an EKG, chest x-ray, some electrolytes. Maybe if they're on a digoxin or any other toxic drugs, just get the levels of those.
Dr. Mallemat, one section I found of particular interest was the section on pacemaker syndrome. Can you take us through some of that?
Sure. So pacemaker syndrome is one of those things that's actually a diagnosis of exclusion. It's one of those things that is not 100% understood, but is believed to be some mild dysynchrony between the atria and the ventricles. But before you get to the diagnosis of pacemaker syndrome, it's important that you go through and, as Dr. Allison said, do a very thorough history, very thorough physical, look for any alternative causes of what this can be, and included within there would be a consult with an electrophysiologist, whereby they can come down with the specific interrogation device and figure out what's going on with the pacemaker, what the person is experiencing on a day-to-day basis with regard to their rhythm. Is there some subclinical arrhythmias that are happening? If it's an AICD, is there any firing that's happening? They can just go ahead and troubleshoot from there. And then once all that workup is done, you may land on this diagnosis of pacemaker syndrome.
This next question is for the both of you. I'll start with you, Dr. Allison. When you were outlining the scope of this article, what key elements were you looking to cover?
I wanted to cover a couple of the things that really scared me when I first saw these complications come into the emergency department. I remember seeing a patient who came in with their ICD who was firing, and I heard one of the senior charge nurses yell, "Get the magnet, get the magnet!" And I had no idea what a cardiac magnet was or what it could do or why we were even looking for a magnetic device. So I wanted to cover the parts about what the magnet does to pacemakers and defibrillators, and it's often something that's covered on on board exams, so it becomes a really pertinent fact to know for those in training and those out of training who are seeing these patients. So the magnet for a pacemaker, when you put it onto the pacemaker, ends up putting the pacemaker into an asynchronous mode. What that means is the pacemaker no longer has a sensing function. It's just going to pace. It paces typically at a rate of 80 beats per minute, but this is set by the electrophysiologist who implants the pacemaker or who follows these patients up. So you can't, with 100% certainty, know what the rate is going to be. But if you put a magnet on a pacemaker, it goes into an asynchronous mode where it just paces at a single rate and it's no longer sensing. This is probably best utilized in a patient that comes in and might have a failure to sense or oversensing. So if the pacemaker is thinking that muscle twitches or maybe a diaphragmatic pacemaker is actually a native cardiac rhythm, it's not going to pace. If the patient's actually in a bradycardia, what they really do need is for that pacemaker to start functioning. Placing the magnet on reverses that dire circumstance and will have the patient be paced at an appropriate rhythm. And then conversely, what a magnet does for the patient that comes in with a defibrillator is that it actually eliminates the defibrillation mode from the device. Most defibrillators, most ICDs are actually both pacemakers and defibrillators, at least the ones inserted in the United States. So when these are inserted, when the magnet is placed onto the defibrillator, it'll stop defibrillation, but it'll allow the pacing mode. So whatever pacing is being done by that defibrillator is unaffected. And when a patient's coming in with multiple defibrillations, it's probably not the smoothest move to put on the magnet right away until you figure out what's going on and what the underlying rhythm is. But for a patient who's having multiple shocks from their defibrillator due to something like a fast atrial fibrillation, and you've taken the time and you've diagnosed that this is aberrant defibrillation due to just an atrial fibrillation, and the device is recognizing the fast rhythm, a magnet can stop the firing, and then you can treat the underlying atrial fibrillation and not shock the patient, make them a whole lot more comfortable.
Dr. Allison covered it pretty well. I would say the one thing that always threw me for a loop was the person that came in with a shock. You know, they came in and they said, I was shocked, and here I am, please evaluate me. And that always made me a little bit uncertain. So I'm sure it makes other people feel uncertain too. And so I think the best approach to a person like that is this. When we're talking about people who have been shocked, the first question we ask ourselves is how many shocks did that person deliver? Now, if they received one shock, most of their cardiologists will actually tell them, don't even bother coming to the hospital because your AICD did what it was supposed to do. We put it in there for a reason, and it shocked you, and now you're feeling better. But sometimes people will come into the ED for evaluation based on that one shock. And I think if you can reassure the patient, if you can take a good history to make sure that there wasn't some new developing problem, such as myocardial ischemia that's developing in front of you, and the patient looks well, they give a good history, then you can talk to their cardiologist and discharge them home, and they can follow up with their cardiologist the next day. But the more challenging thing is the person who comes in with multiple shocks. And the person that comes with multiple shocks, now you have a branch point, and you're trying to figure out whether or not that shock was appropriate or inappropriate. Meaning, does that person have a problem that's developing to the point where they're receiving multiple shocks and the defibrillator is doing what they're doing, but their disease is getting worse? Or was the shock inappropriate in the sense that now this person is getting shocks for no good reason, and how do you handle that? And the best way to do that is, like Dr. Allison said, just go through the simple things, like taking a very good history, doing a good physical exam, getting an EKG, and even putting them on the monitor so that you have continuous EKG recordings to see whether or not you can capture that problem that's happening on the screen and correlate it with the shock. Doing a good chest x-ray to make sure there's no malfunction of the leads or the leads haven't migrated out. And then doing some electrolytes to make sure that the person isn't getting shocks because their T waves may be a little bit more peaked, or there may be some abnormality in the EKG that the defibrillator is interpreting as a bigger problem. And those people are ultimately going to be admitted once they have more than one shock because they ultimately need to be interrogated in addition to cardiac monitoring overnight. So that's the thing that I think is sometimes the most diagnostically challenging, the person that comes in with one shock or multiple shocks.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today focusing on cardiovascular emergencies, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter @eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Upcoming issues of Emergency Medicine Clinics will focus on psychiatric and behavioral emergencies in November, respiratory emergencies in February, and in May, abdominal and gastrointestinal emergencies. Thank you, and we'll see you again next time.